Thank you so much, sir. And it's an honor to be presenting before this August gathering. And I owe everything to these two great institutions, Don Bosco School, Park Circus, and National Medical College, Calcutta. So,
Dr. Dhanashree.
Subretinal membranes, also known as retinal bands of membranes, are a well-recognized complication. They form a part of the spectrum of the whole PVR, as we all know. And in this process, just to a small word about the pathogenesis, RP cells migrate from their normal monolayer into the subretinal space and undergo metaplasia into macrophages and myofibroblasts-like cells that proliferate as sheets. Epithelial mesenchymal transition is the thing of the RPE which might take place and is involved in the PVR process. So the two main types, the diffuse cell sheets and bands. The diffuse cell sheets they lack there is lack of collagen in these glial cells, so they rarely contract. And these membranes are thin, and therefore they rarely cause any structural changes so as to necessitate any division or removal. So most of the cases, these cell sheets need not be removed. But the taut bands containing myofibroblasts which raise the neuroretina and impede the conventional reattachment anterior-posterior is composed of 95% RP-derived cells with fibrin and collagen. This usually requires surgical division or removal. These are the morphological types of subretinal PVR: annular strands, linear strands, moth-eaten appearing sheets, as we see in these pictorial representations. And this is a very important study by Lewis, which stated quite early, a few years back, that only 28% of the subretinal bands require removal or transection during vitrectomy. And the second part of the study, they said that the patients who do not require removal have relatively better visual prognosis. This particular aspect has undergone a sea change due to the techniques and instrumentations that have evolved over the years, which I'm going to show. So we have to be also sure when not to remove these bands. As you can see, when I play the video, that these subretinal bands is extending from the macula right out to the periphery. So a simple depression test after putting PFCL, which will help you to ascertain whether it needs to removal or not. As you can see, if you depress, it plays along with the retina, and it doesn't. There is no tautness on, so the retina, the bands need not be removed. So surgical management of subretinal band removal is of PVR, as stated so eloquently and excellently by Pramod. In fact, Pramod's act is a very difficult thing to follow, as I was telling him. So closure and sealing of all retinal breaks and release of periretinal traction is the two major principles. And to this, it's out of the scope of this lecture, but prevention of recurrence should be the part of management. Key points are that sheets, as I told you, they never cause enough force to prevent attachment. Bands sometimes have to be removed, not always. Like in this case, as Madam Dr. Subhadra had pointed out, that buckling surgery has a role, and these bands were settled by buckle alone. Of course, the case of detachment with subretinal bands, we settled, and these bands need not be removed. First, the techniques of removal are, if a retinotomy is there beside a subretinal band, so a separate retinotomy, you can remove the band through the existing break if it is adjacent to the band. And if a retinotomy is needed, so the location is very important. It should be beside the thickest part of the band, and the direction should be ascertained that the forceps should enter the tangentially and as tangential as possible. So the location of the retinotomy is very essential, as I will show in the video. So this is a pictorial representation, as I was saying. So these are the ways to grasp the band unimanually and bimanually, as will be shown in the videos. So I won't elaborate here. And principle, one should be careful never to use diathermy over a band to create a retinotomy, as this can sever the band. Sometimes these bands are strongly attached to the underlying epithelium, so best to cut these bands in places rather than removal, because that can lead to a lot of bleeding. But when there is a diffuse network of subretinal proliferation bands, then it's prudent to take resort as a last resort, as Dinesh has said, of a retinotomy, which should be extensive if one has to make a retinotomy. So I would like to show you a tug-of-war technique which has evolved over the years, essentially started by Dr. Cyrus in epiretinal band removal, which can be extrapolated to subretinal band removal also by using two forceps or a combination of forceps and spatula. So this is a case where we definitely need to remove, as you can see, and there is a network. So we need a retinotomy to remove these bands using two forceps technique. The direction of the forceps should be tangential to the surface of the retina. That's the basic thing. So, and one can go very posterior if need be, sometimes up to the disc, but very carefully. Remove the extensive network of bands, and then you use perfluorocarbon to, after removing the bands, you use perfluorocarbon and settle the retina and do laser and PF silicone exchange. And just a small point regarding if you do a 360 retinotomy, then I usually give oblique cuts medially, nasally, and temporally, because otherwise there will be a PVR contraction folding. So this is a small trick. So this is another case where after repeat surgeries, patient presented to us with subretinal silicone oil, which was removed, and these bands were exposed. And again, thorough retinotomy was made because the retina had so I'll go to the next video. So just a small word about ab external subretinal removal. Wolf had started this, and here you make a retinotomy, but it's usually before the vitrectomy. Band removal is made, and Rupok here does a lot of the subretinal band removal here. So it's usually done, as I said, and this is the last part of the video, showing the tug-of-war technique. 2-minute video. So retinotomies are made adjacent to the bands and removed, as is seen here. There were two areas where they needed to be removed. If it is localized like this, it's good to make two small retinotomies, but these extensive networks need to be dealt with bimanually. And as I said, two forceps using, I'll just try to fast forward.
Can we conclude, Dr. Jayanto?
Yeah. And that's the end of the surgery, the previous one. And we go to the last part. Here spatula and forceps being used. And these two videos, the last two cases were, one had to combine with a autologous retina transplant because there was a huge macular hole involved along with a re-RD. And the last one is about foreign body. So,
Dr. Dhanashree, can you take to the dais?
Yeah, just finishing. And so this is a case where after removing the bands, then the autologous retina transplant was done, taking retina from the periphery. Here I'm putting the transplanted retina onto the large hole, and the last part is we remove the foreign body which was which got embedded near the fovea, and through the pre-existing break, the subretinal band was removed. Thank you so much for your